Hello, my name is Heather Peabody, and I'm an occupational therapist from Nashua, New Hampshire. This course is Dementia Management, Advanced Skills for the Healthcare Practitioner. I've been practicing occupational therapy for 14 years. I've worked 12 in nursing homes, home care, and right now I'm working in a hospital. I worked in school systems for 3 years while simultaneously working at a skilled nursing facility. I started as an intern at a geriatric research program in Massachusetts called GRAC through their city VA. And since then, I've decided to specialize in this topic. I've written a book, Not Just Alzheimer's, a strategic guide for all dementias, also some training books, 10-minute in-services on dementia, 5 one-hour course modules for nurse assistants, and enhancing the quality of life for long-term care residents. Basically, that's an FMP and restorative program manual. In this course, we will discuss dementia etiology and staging. The doctors may be asking you as a skilled clinician to be staging your clients. We'll talk about management of dementia. That will be the bulk of the course. Care planning, I'll give you some tips and books with pre-written care plans and goals. Which assessments and evaluations may you be interested in administrating? And screening and staff education. How do we get the rest of the team to follow through with these wonderful recommendations that you've made from your findings? Sometimes it feels like our coworkers have dementia. And they do. Our cognition waxes and wanes throughout the day. Sometimes you have lots and lots of room for processing, sometimes very little, like when you're busy or when you have many demands put upon you. So we'll kind of talk about how to get into other people's heads and get them to follow through, see why they might not. If you ever want to keep in touch, my website is thedementiaspecialist.com. On my website, there are links to resources, other books that I sell online, video tutorials linked through YouTube, which are free for you to watch and share with your team. You can also contact me through that website, thedementiaspecialist.com, with any questions that you may have. Let's start by going into the dementia etiology and staging. We'll start by looking at the brain, and we'll talk about differential diagnoses, staging, general prognoses of the most common and some rare dementias, how to effectively communicate with this population. We'll look at the sensory systems, how they are affected by dementing illness, and comorbid diagnoses. What do they do to cognition? What do pseudodementias, reversible dementias, and delirium mean? We'll start with the brain. A firm grasp of neurology is essential in understanding why our clients are behaving the way that they are and really help us predict their levels of capability. It'll also give you a wonderful vocabulary to fill out your evaluations and care plans and to come up with reasonable outcomes that your clients will meet. Dementia can affect any area of the brain, so we'll do a pretty thorough but brief neuro review, brief so to speak, because you could get a doctorate in it, but I think we're going to spend about an hour on this topic. Think of your brain as 3 brains. You have your midbrain structures responsible for a lot of autonomic processing, including fight or flight type of response. This area could be affected by dementia. Then you have the external cortex area. We say that's responsible for executive management functions, and there are 4 major lobes on what we call the cortex, or cerebrum, or cerebral cortex, or it could be responsible for many options that could be affected by a dementia. Then you have the cerebellum responsible for motor praxis. These are your recipes for movement. So your 3 brains really work together as one cohesive brain, making you. And dementia could affect any portion of them. Let's talk about how it could. I like to use candy when we're talking about Neuro Anatomy because a lot of people get very intimidated by the neuro. And why wouldn't you? With the nomenclature, there are so many different monikers for the systems and an anatomy that we're looking at that sometimes one neurologist doesn't even know what another neurologist is saying. But I do want to let you know that neurological care is about 20 years behind cardiac and orthopedic care. So some things we're still figuring out as we go. There's a number of periodicals that have been coming out this year, and just really digging into the neurophysiology and etiology behind the illness. So I'll try to keep you up with what I've been reading, but I know far less than somebody who makes this their life's work. Okay, so right now what we are looking at is the cerebrum and the cerebellum. The cerebrum is that cortex that we were talking about, and I'm representing that with circus peanuts. On the outside of your brain, you have sulci and gyri. Gyri comes from a Greek word gyro, meaning to twist and turn. And what you do see are these convoluted areas of matter that do twist and turn around one another. Ever order a gyro from a Greek restaurant? Just think about how the meat is cooked, and then you'll learn the terminology. I know there's a game that I love to play with my children called Gyro, 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 Gyro. We would sing, and my daughter Athena, when she's a baby, she would spin and spin until she fell on the floor. It was fun for her as well as the grown-ups watching. And sulci means crack or crevice or space, and that's what we see in between the gyri. The cerebellum is represented by the rainbow extreme Twizzlers in the back. That's responsible for motor praxis. Think of Neo from the Matrix. He gets plugged in the back of the head to learn jujitsu. He's basically uploading it to the right area. So if you think about the back of your head, that would be an area that could be affected by mostly traumatic brain injury, but it's an area that's relatively strong with dementia. I'll talk about places that have deficits in the brain, but we'll also refer to areas that have superpowers, and we'll cover them as we get to them. Let's start with the cortex and work our way in through the neuroanatomy, talking about how your client's abilities to function may be affected. Frontal lobe is located in the very front of the cortex, and it's easy to remember where it is and what it's responsible for by a simple gesture. You hold your hand in front of your head and hit it. Oh! You just located where it is, named it, and hit it for the right reason. This is the structure responsible for executive management functions of impulse control, personality, divergence. Divergence is when you anticipate mistakes before you make them. You anticipate problems before they happen, and you fix those errors before they're even made. Psychologists believe that not everybody is capable of that ability, and I would agree. Otherwise, we wouldn't have the judicial system or financial managers. Frontal lobe is also responsible for judgment. Should I have done that? Maybe some simple etiquette type of behaviors. Organization is discriminating important stimuli from unimportant stimuli, which can also be affected. That's a learned skill. I mean, I think of some people that I went to college with, and they highlighted the entire textbook because all of that was good. Volition is your get up and go. It's like initiation of activity. And we develop that skill as children. It starts to get a little latent in the teen years where you need to wake someone up at 12 o'clock in the afternoon, say, hey, it's about time to get out of bed. But then it comes back, hopefully. We see in mid-stage dementia a lot of avolition, and according to Reisberg's theory of retrogenesis, you may equate someone in mid-stage dementia to a similar way to process information like a teenager. And we do see that they may need someone to remind them to get out of bed, and if we don't, they may stay there until noon as well. Frontal lobe is also responsible for emotional control. This is composing yourself. You may feel one way inside, like your midbrain or your hypothalamus, but on your cortex you show something very different. Maybe deep inside I have deep-seated issues and I'm very, very sad, but I can smile at you and make you think that I'm okay. See, I'm fine. That would be a very good frontal lobe ability, and according to Star Trek, Vulcans are very good at it. The parietal lobe is located at the top of the cortex, responsible for sensory and motor processing and motor output. This is where we had learned about the homunculus, and if you watch The Big Bang Theory, you'll hear Sheldon refer to his roommate as his homunculus, which means little man or man of little stature. Your brain has a map of itself, how it feels itself, and sensitive and dexterous areas have very prolific neuronal space. So if your body were to map itself through proprioception, how it feels itself, how it sees itself without your eyes, those sensitive and dexterous areas would be larger than those that are less sensitive. And what I have as an example here is a possible homunculus of your hands, where you can feel the fingertips. They're much more sensitive than the palms of your hands. Your lips would be very large on the homunculus, whereas your cheeks would be smaller. Lips, nose would be large. The occipital lobe is located in the back of the brain, and it is responsible for visual processing. It is often also referred to as the visual cortex. According to Mary Morse, a vision specialist in New Hampshire, vision can take up to 75% of your brain, but we're talking about a very simple way to understand vision. Vision is usually mostly processed in the visual cortex, in the back of the cortex. So what I want you to do is please remember the occipital lobe. This is an area of superpower for clients that have dementia. It is an area that is very little effect to it from a dementing illness. You will find that when someone has diminished skills in one area, they may have savant type skills in another area. And this we do see with dementia. For example, our clients do write a lot of things down to compensate for their difficulties with their dementia. They use their calendars. They tell you, don't you dare bring in that adaptive equipment into my home. Everything's there for a reason. Don't move the furniture. Don't take the throw rugs. Everything's supposed to be there, and if you move it, I get very, very upset and obsessive about it. So visually, I want a familiar environment. I will use visual reminders to help compensate for my deficits. That will be the most important, is keeping the notebooks. We also see that they look at your facial expressions to help give them tips on how to perform by looking at the gestures that you provide to them. And if you are an expressive sort of person, then you may have a client who does much better with you than maybe with another caregiver, or maybe they do much worse with you than another caregiver because you're expressive. So, for example, let me say that I look at a client and I say, well, where would you find the cups so that we can make some coffee? And I really have to have a poker face if I want to see how will they perform when I'm not around. If I don't make that poker face, then I might look at the cupboard by accident, or smile or nod or make a little kind of expression, and the client would be able to find those cups, and it would not have been a natural assessment saying, how will she perform if I'm not there? Now, if I do take away those visual cues that would be enhancing the client's performance, and maybe you don't know how to yet, you could always put a book in front of you when you ask the question, hey, where would you find the cups? And at that point, your client, being frustrated that this is a challenge well beyond their ability, may say, you got me, I don't know where they are. Or maybe if they're in denial is manifesting, they may say, why would I try to find a cup? That's stupid. So vision is a superpower for dementia. But vision can also be affected by dementia. There are specific areas where the client may have a lot of difficulties, like visual discrimination. Paisley wallpaper would be terrible for the client who has dementia. Decorated carpets would also be difficult for the client. Black, because of depth perception issues with dementia, we avoid black. Black could be perceived as bugs, trenches, holes. To put a black carpet in front of a door, the reason why the client won't leave the area is because essentially you've put a hole in the floor. I personally do not recommend putting a hole in the floor in your client with dementia's reality. I find it very distressing in real life to be in a room with a hole in the floor. So it's usually not a technique I feel very good about. There is a very good resource on wandering from the Futrell article, which I'll be referring to later. They had come up with the Wandering Outcomes Monitor out at a school of nursing, I think in Iowa, and I'll share that information later today. What else? Visual spatial relations. They'll also have a hard time with that. If, let's say you had a locked keypad to a dementia unit, a client who knew the numbers could enter them on that pad. But if you were to take the pad and turn it upside down and install it upside down, the client who may know the code may not know where those numbers are because of the visual form or visual spatial relations. I mean, neither would your coworkers, and it would be kind of fun to watch them have a difficult time. I see people casually try to look upside down to enter the code. The temporal lobe you can think of as being next to your ears for a reason. It's highly responsible for language expression and reception, also for understanding symbolism, like rubber ducky means bath. In the Wernicke's area, that's where we process time. We have clients who have Wernicke's encephalopathy or Wernicke-Korsakoff syndrome, and oftentimes there will be symptoms of an amnesia. They may think that it's 10, 20 years ago, and to give them reality orientation would be very traumatic. The Wernicke's area is affected with nearly every one of my clients that has an irreversible dementia. On the clinical interview, I often ask my client, "How old are you?" before we even get into the question, "What is today's date?" And oftentimes my client will give me an age, if they have dementia, that is not accurate to what their age is. Maybe they say, "Oh, I'm 40." And then when I do the reality orientation, I say, "Well, actually, it's 2013, they say, "Right, I'm 85." And it doesn't seem to really bother them that they made that mistake. That's because caring about time and age, it just really isn't there anymore. And why would I want to know how old they think they are? Well, it'll give me glimpses into what dimension they're in later today, when perhaps she's waiting to go pick up her kids from school, or asking where her mother is, or where her husband may be when her kids are all grown up in this dimension. Her husband has passed away, or her mother has passed away. We also see that environmental awareness is processed in the temporal lobe, and if there is damage in that area, the client may have difficulty driving, navigating to areas that they need to go to, finding their room, may all be very difficult. We can say they have a mini Garmin in there, which could be affected by dementia. As I said before, the cerebellum is an area of motor praxis, but I do want to let you know that with dementia, this is an area of superpower, specifically residual motor praxis. Anything that I've learned on how to coordinate, move, kinesthetically remains relatively intact with a dementing illness. The issue that is the problem, it's new learning. Clients have very limited neuroplasticity with dementia. Neuroplasticity is the brain's ability to change. So learning a new way to move and coordinate would be extremely difficult for a client with dementia, like learning how to use a walker. As a clinician, I may find one of my coworkers saying, left foot, right foot walker, left foot, right foot walker, left foot, right foot walker, in training their client how to use their mobility device. Yet clients who had a mobility device before they were showing any symptoms of dementia, before they're even diagnosed with dementia, uses these mobility devices with ease and does not have to be trained. We give our client a rolling walker, and left foot, right foot walker, left foot, right foot walker. Yet they barely move. Yet you give them a rollator and we're saying, slow down, lock the brakes, slow down, lock the brakes. Because a rollator pushes like a stroller or a shopping cart, and these are in the client's residual motor praxis. So oftentimes I will talk to clinicians like therapists or people in activities departments, and I say, if you're trying to do an exercise group, your client may have a difficult time learning how to isolate muscle groups for exercises if these are exercises that they've never done in their life before. Like with therapy bars or therapy bands, we may see that clients get confused when you ask them to do the more difficult activity. What I often tell the clinician is, what would Mr. Miyagi do if you were training the Karate Kid? He'd give the Karate Kid simple chores to perform that would repeat those motor movements. And through these chores or these games or these activities, the client would improve the use and agility of that muscle group. So many times I just play games and I find that my client has good form. I take the therapy bar and I say, sweep the floor. And then with your other hand, sweep the floor, or I might say, row the boat. Or with the TheraBand, we might play slingshot and knock over some cones, which is more of a game that may tap into their residual motor praxis. And I'm always trying to come up with what is the game or the activity to isolate the motor movement. PT, have your clients kick a ball, do the ramba, do the samba, wheelchair races, rather than trying to just do adduction, abduction, or flexion, extension, hip rotation. We always just want to try a game. And I found that myself. I'd have the ring arcs and I'd ask the client to do the ring arcs, and then, they'd grab all the rings and put them on the other side. Done. Be much more successful asking them to wash a window. So based on impairment to the cortex or the cerebellum, we develop a vocabulary of potential difficulties that the clients may have with their dementia. Your client might have increased impulsivity, decreased judgment or safety awareness, decreased visual perception, difficulty following directions. And that's key. Don't say that they don't follow directions or that they're non-compliant, because that is implying a certain level of willfulness and that I want to quit on them. Claudia Allen, with a can-do type of philosophy with her performance modes, strongly suggested that we talk about what they can do, not what they can't do. And rather than say can't, we would say has difficulty. Decreased volition, which we would call avolition, decreased motor praxis, which could be sequencing or motor coordination deficits. And I'm often billing for that more than a weakness code with dementia. Decreased environmental awareness, at risk for social isolation because of the avolition, combativeness, decreased insight, and absolutely behaviors. The bisection was harder, but I love you, so I put forth the effort. This is the best way to look at those midbrain structures that could be affected by a dementing illness. What I did here is I created a hemisection to the brain, and we're looking into the right hemisphere. Right underneath the marshmallows, that's representing the cortex, is a bunch of starbursts right in the cingulate gyrus. It's representing a group of fibers that helps connect right brain to left brain called the corpus callosum. The corpus callosum is key in understanding symbolism, language, and bilateral motor coordination. And this is another area that is relatively strong with dementing illness. It has very strong connections, so if your client is having difficulty in any of these performance areas, I would say work on one of those other two skills to help get them there. Your brain is like a highway. It's not really like a muscle. It's like a highway. And the more you use a road, the stronger it gets. The more a neural pathway is used, the stronger the practice. Practice makes perfect. Practice makes praxis. Let's say you have a client who has Parkinson's disease, and then you want to go work on bilateral coordination. It may be prudent to have that client see their speech pathologist first and then work on some word and memory retrieval games, symbolic reasoning, like what's bigger, an elephant or a mouse. Motor coordination. Let's say you have a client who has excellent motor coordination, but they're having poor verbal skills. Perhaps you'll go work at the parallel bars or do Parkinsonian type exercises with your client before you go work on symbolic reasoning and language skills. If you want a higher level treatment for this area, look into products like Brain Gym. A group of physical therapists in Massachusetts had come up with activities where the client does bilateral coordination, crossing midline, a lot of balance and multitasking activities. And research has shown that these kids have better coordination, better balance, and better able to comprehend reading and writing in class. Leonardo da Vinci did this kind of stuff every day. He used to draw with both hands at the same time, or write with one hand and draw with the other. Brain Gym has that as an activity. It's called double doodle. The basal limbic group is often affected by a dementing illness in the midbrain. Now, when we were looking at the cortex and the cerebellum, we may have a vocabulary that says the client may have an increase, a decrease, or a disturbance in function if that area of the brain is affected by the dementia. But in the midbrain, let's just say it kind of works in binary. It's a very simple system, and things can get either stuck in the on or off position. So lability would often not be a midbrain problem. It would more likely be a frontal lobe problem. Whereas an excessive emotion could be on the cortex or in the midbrain. Let's look at the basal limbic group and how it could be affected by a dementing illness. The hypothalamus is part of the limbic side of the basal limbic group, and it is responsible for secreting chemicals and neurotransmitters to regulate these systems and functions: hunger, sleep, emotions, temperature, sex drive, and osmotic pressure, which is blood pressure and blood volume. In dementia, at about mid-stage, these can be stuck in the on or off position, and oftentimes we have some very interesting care plan meetings that we're sitting in as clinicians. Dr. Walliser had pointed out very early in my career to me, when I was at the GREC program, that in mid-stage dementia gets the munchies. Hunger gets stuck in the on position, and the client will be insatiably hungry for about 6 months. And after 6 months of significant weight gain, that hunger shuts off, and the client is not hungry anymore, and you'll have a heck of a time getting them to eat. Now, if you're thinking MDS type of documentation, this was an expected weight gain followed by an expected weight loss. With the Affordable Care Act, you should not be penalized for this happening with your client. It was part of normal dementia etiology. What Dr. Walliser had recommended was not to put these people in the munchies phase on a diet. You put hungry people on diets, I'm going to tell you from my own experiences, you get behaviors. Maybe they'll tell the state surveyor that nobody ever feeds them. A very serious thing, but the client may not remember that they just ate. Or maybe they find a supplier of unhealthy food. They often do. Dr. Walliser said, think of it as a bear. getting ready for winter. This will serve as a calorie reserve for the significant weight loss that will occur later. Just an idea. Sleep can be disturbed. That's called a disturbance in diurnal rhythm. And I would say the best non-pharmacological intervention to help fix sleep patterns is to give them activities to do all day. Very difficult if you're having staffing issues at your company. The most common intervention is actually something like Lunesta because pills are faster. But with someone who has an irreversible dementia, you put sleeping pills on top. That's additional pseudo-dementias that can bring their cognition down, down, down until they have sensory deprivation. Sleeping all night but catnapping all day, and it's a significant problem. Emotions can be stuck in the on or off position. When in the on position, this may be pseudobulbar affect, and the drug of choice for that nowadays is Nuedexta. Nuedexta is the only way to find out if it is pseudobulbar affect, because once the client starts taking that medication, if the excessive emotions go away, then yes, it was pseudobulbar affect. If the excessive emotions do not go away, then it probably wasn't pseudobulbar affect. Perhaps there's a lesion somewhere else in the brain, or it's a cortical disorder. Tough to tell. You may also have lack of emotions, like a flat affect. Typically, we're seeing that with a frontal dementia, but if it is deep, deep down, you might think of that as definitely a flat affect from midbrain. Masked affect is more of a muscular type of issue that we might see with Parkinson's, whereas their face kind of gets stuck in this brooding kind of position. I kind of think about people who had Botox and can't move their face very well up here. Masked is pretty much the whole face, just kind of like this. Temperature can be tampered. I have people who are chronically cold, chronically hot. I was being told the other day that people with Parkinson's can frequently feel cold because the thermal reg gets affected from midbrain damage. Sex drive can be stuck in the on or off position. Healthcare clinicians often don't gripe about sexual activity in the off position, but when stuck in the on position can be difficult and challenging. Huntington's chorea, for example, can have hypersexuality. Some spouses think of that as a superpower. Osmotic pressure is typically not affected by a dementing illness, so far as the data of this presentation. The thalamus is considered the gateway for your sensory nerves. 6 out of 7 of your senses contact the thalamus. Information is registered, a response is modulated, and then that information is sent up to the cortex to be processed and responded to through sensory regulation type of behaviors. So we process senses twice, once in the midbrain, once on the cortex. The one sense that does not go to the thalamus is the olfactory nerve. All of the other senses don't like him because he smells. So he goes over to the basal ganglia, part of your primitive midbrain. And interestingly enough, your olfactory nerve is one of the first senses lost with dementia. Your sense of smell is your foundation for developing memories. And your sense of smell gets lost at absolutely the most horrible time in dementia, mid-stage, right when the client loses their appetite. Your sense of smell works with your gustatory sense, which is your sense of taste. With diminished smell comes diminished taste, and with disinterest in food, our clients don't have anything really motivating them to eat. But with the decreased smell, the last 2 taste senses remaining are salty and sweet. So we find that clients with dementia have a tremendous sweet tooth, and one intervention that I would strongly recommend is to sweeten up your client's food. I will mention a lab later on how to get your clients onto a sweet diet, because your coworkers might not be so cool about that. That's always watching the bulge, but it may be the best way to get your clients to eat. The hippocampus is nearly always affected with dementia, and absolutely always with the irreversible dementias. And that was found with Kodama and his team in Japan, that nearly everyone who had an irreversible dementia had hippocampal atrophy. The hippocampus is strongly related to memory, short-term memory, and working memory. Short-term memory and working memory are kind of interchangeable terms. Working memory is kind of a little longer than short-term memory, but can overlap short-term memory functions. Working memory could be anything that you keep in your mind for maybe months, weeks. Short-term memory is usually about 0 to maybe 15 minutes. Just roughly. All the literature does not agree with each other. Long-term memory is stored everywhere on the cortex. But yeah, you'll notice with people with dementia, it's the number one symptom. They are a forgetful sort. They have difficulty with new learning. So we have some more vocabulary generated by the Neuro Anatomy for you to write on your evaluation. Your client may have decreased coordination, excessive emotions, short-term, long-term memory loss. They may need repetitive training, or perhaps you want to say sustained training. A decrease in working memory, decreased bilateral coordination, decreased symbolism, decreased language skills, decreased time management. They will also have a decrease in sensory processing. Let's look at how the basal limbic group processes sensory information. All 7 of your senses contact the thalamus and the basal ganglia: visual, olfactory, taste, auditory, tactile, vestibular, and proprioceptive. Then information is registered, a response is modulated, and then sensory information is then sent up to the cortex to be processed again. And because dementia could be affecting the midbrain here or on the cortex or both, your client has a sensory impairment. When clients have a sensory impairment, they will need extra time to process sensory cues. And those cues may need to be repeated because of the short-term memory loss. Welcome to the hardest part of your job: waiting and repeating yourself. Wait at least 60 seconds until the client has a chance to process and respond. Then repeat yourself in case there's some data still residing in their working memory. They may also benefit from having multiple types of sensory information to convey messages: tactile cues, auditory cues, visual cues, etc. Your client is at risk for sensory deprivation and overstimulation because of this length of time needed to process information.